Great, thank you. We've organized each of the listening sessions by stakeholder or constituency, as you can see here. So we've completed over the last several days listening sessions with multilateral, private sector, and foundation partners. We've completed sessions with civil society and communities, partner governments from ministries of health as well as ministries of finance, implementing partners all across the board. We recently completed a listening session with the Scientific Advisory Board for PEPFAR. And here we are today with the US government, which we're very, very excited about. This involves headquarters as well as country teams. The format for each listening session has been very similar in that we'll provide a brief epidemiologic and PEPFAR overview. We'll have a facilitated panel who will be providing reflections. And then we will open it up for all attending to provide inputs and thoughts for consideration. We have a rapporteur for each session that will then summarize the key themes. As I noted earlier, all sessions are recorded. We're going to be sending out this PowerPoint presentation, and the links for each will be made available on our website. So moving right in to the global HIV/AIDS situation and taking a look at the epidemiologic trends over time, we see that we've made significant declines together in new infections and deaths since 2003. When you look at the graph, particularly on the left, and this is really thanks in large part to the dedicated resources and efforts by all of you in working together with countries and communities to really scale up HIV treatment and prevention programs, particularly in sub-Saharan Africa, but really across the globe. Again, really tremendous impacts that have been made thus far. Looking regionally, we see here Eastern and Southern Africa with the most significant epidemiologic impacts. And this is a result of controlled epidemics in many high-burden countries. Here we see trends in new infections and deaths in the two graphs on the top, distribution of new infections by population in the bottom left, resource needs and the availability of resources, and then the treatment cascade as well as gaps. Here in Western and Central Africa, again, the similar data bringing to bear here, we see continuing declines. New infections are predominantly among key populations and clients of sex workers and partners of key populations, and resource needs are growing here. In Asia and the Pacific, we see continuing declines, new infections concentrated among key populations, and resource needs growing as well. And in the Caribbean, we also see continuing declines as well. In Latin America, we're at a relatively steady state, as you can see. And in Eastern Europe and Central Asia, we see increasing trends in new infections and deaths, as you can see here. What has remained consistent is the unwavering bipartisan congressional and presidential leadership and support of PEPFAR since its inception in 2003. The other thing that has been absolutely unwavering is your collective effort on the ground and at headquarters to really continue to drive forward in such challenging and difficult times, but always dedicated to the mission. As you all know, provide support through PEPFAR in 55 countries, and our investments are aligned to the HIV burden of disease. Here's a very brief snapshot of a summary of our latest program results, and this is for the most part as of fiscal year 21 quarter 2. So we currently have 18.2 million people on life-saving treatment. This is an additional 1 million in the first 2 quarters, I should say, of this year. We have 26.8 million circumcisions that have been completed cumulatively as of fiscal year 21 quarter 2, 6.7 OVCs and their caregivers provided with critical care, and 5.6 million as of fiscal year 21 quarter 2. We continue to make important progress in DREAMS as well as other indicators across the program. You've seen this graph before. Here we see the trends of the PEPFAR budget in the blue line and the blue increases in results for VMMC in yellow and treatment in the blue bars. Again, this is only as of quarter 2, so we'll be updating these results over time. Our commitment to treatment continuity and growth is clear, and you all have instituted and implemented real-time program adaptations to really ensure that we maintained our services. You can see here, even through peaks in COVID-19 as depicted here in peach. And we're seeing significant progress toward UNAIDS 95-95-95 goals. Here, you've seen this graph before, our select countries across Africa that have completed the FIAs, and the results are indicated here. And of course, community viral suppression in orange. We've made strides together in a number of public and private partnerships. Here is DREAMS, again, significant results related to preventing new diagnoses and infections among adolescent girls and young women through DREAMS, but there are also a number of other public and private partnerships where we've made significant progress together. And we continue to make progress and see gaps in our key populations programming. And here we see by key population, and we see really the full cascade, including prevention indicators. We're going to go quickly over these next set of slides, but this is to show that there are a number of countries at epidemic control of HIV. And I just want to call out and thank UNAIDS for much of the data in this presentation, but particularly here. So these are a series of countries at epidemic control of HIV. We see Zimbabwe, Kenya, Malawi, Lesotho, Ethiopia, Rwanda, Eswatini, Thailand, Nepal, Cambodia, Burundi, Cameroon, Cote d'Ivoire, DRC. And here we see Burkina Faso, Senegal, Togo, Mali, Liberia, Trinidad, and Tobago. The next series of countries are those that are near epidemic control of HIV, and these include Botswana, Haiti, Uganda, Vietnam, Guatemala, and then we've got a number of countries with declining new infections, but not yet at control of HIV. And these include Angola, Ghana, Mozambique, Nigeria, South Sudan, Ukraine, Tanzania, Zambia, and South Africa. And again, just to note, you're all familiar with these graphs, that the y-axis is very different as we look across these countries. And another series of countries not at epidemic control of HIV, Tajikistan, Indonesia, Panama, Guyana, Jamaica, and the Dominican Republic. Looking briefly at gaps, opportunities, and the end state. Again, showcasing important data from UNAIDS in terms of distribution of new infections and by age and sex, just to make two important points here. First, in sub-Saharan Africa, despite the gains that we've seen in those epidemic curves, 52% of the new infections are among 15 to 49-year-old females, even though they account for 24% of the total population. We must continue to decrease new infections in this population, particularly with the youth bulge. And second, there's variability of coverage and accessibility of critical HIV prevention services for key populations across countries and regions. So we must continue to address barriers for these populations. Here we see coverage of ART by adults and children over the last decade, and 2 points to make here. First, 40% of children living with HIV had suppressed viral loads in 2020, as you can see in the rightmost part of the graph, compared to 67% in orange, which are adults. And then nearly 2/3 of children not on treatment are those aged 5 to 14. COVID continues to be a vulnerability affecting the program and the beneficiaries and all of us, frankly. You have been instrumental in adapting the program for the past 18 months to protect the gains, to continue to accelerate the work for the people we serve, and also to help respond to COVID-19. And this has really been extraordinary. You've done this by engaging in all aspects, particularly utilizing the PEPFAR platform that offers a care delivery platform, by leveraging the labs, the healthcare facilities where we have access to clients and data, by leveraging the healthcare workers and community health workers, as well as the supply chain. Here, we're just noting the HIV investment by funder in PEPFAR supported countries. And what you see is in red, which is PEPFAR resources, in blue, the Global Fund resources, and then in gray, the domestic resource contribution. Orange is the other funders. Again, it's a shared investment here across the countries, and it varies as well by countries. Here we're seeing projected gross domestic product growth versus HIV prevalence. And again, economic problems from COVID continue to persist across the board, but they're worse in countries with high HIV prevalence, as you can see in the red dots, as well as by income status, with the higher income status countries toward the right side of the graph. One of the key components that we've all been driving toward together is our approach to sustainability by delivering HIV services through local and community partners. We currently have, as you can see in the leftmost graph, 55% of new funds in blue going directly to local partners. And this varies by country, by agency, and also by program area. So in the middle, you can see care and treatment and the percentage that's going to local, which is at 54% overall versus 46% to international, and then prevention, which you can see in the rightmost graph, where we have less than 40% going to local partners. So in the end, what does sustained response look like? And there are a number of factors here that we have listed. Whole of domestic approach from government to community to successfully sustain epidemic control of HIV. Sufficient functional, technical, and managerial capacity for maintaining the programs. Financially sustaining essential services. HIV service delivery integrated into broader public and private care delivery systems. Ensuring that there's robust public health response in place to monitor and track existing outbreaks as well as emerging threats, and quality assurance to ensure positive health outcomes. So with that in the backdrop, this brings us to what we're here today to focus on, which is the PEPFAR 5-year strategy development. So we started developing the strategy with all of you as well with all of our stakeholders since last fall, as bulleted here. And again, we look forward to these conversations as well as others as we continue to develop the strategy. Again, these listening sessions are absolutely critical. And as we noted earlier, we've had several of them, and we're really, really looking forward to this USG panel today. The feedback will both feed into the strategy itself, as well as we think about COP20 and ROP22 guidance development, as well as longer term planning. And so for this 5-year strategy, we've really tried to make sure that we're focusing on achieving sustainable, equitable, and resilient control of HIV in support of the global efforts related to SDG 3. And again, ensuring that we're closely coordinated with the Global AIDS Strategy of 2021 to 2026 that UNAIDS recently released, as well as the Global Fund strategy that is in development for post-2022. And here, I won't I won't go into all the details because you've received all of the goals as well as proposed objectives in PDF form over the past several weeks in particular. But there are 3 proposed goals and a series of objectives under each. The first goal is to accomplish the mission 95, 95, 95, sustained, equitable, client-centered HIV prevention and treatment services, supported by 6 proposed objectives listed here. And the second goal is to build enduring capabilities, resilient and capacitated country health systems, communities, and local partners, with 5 supporting objectives listed here. And then finally, goal 3 is to broaden the base of support, partner for greater impact, burden sharing, and sustainability, with these 5 objectives proposed here. I'm really excited now to hand over to our esteemed facilitators, moderators, and panelists. So I will turn to Dr. Ade from HRSA, and Shannon Young from USAID, as well as Brendan Garvin from SGAC, as well as the entire panelists. So Ade, over to you.
Thanks so much, Anjali, and greetings to everyone. As Anjali mentioned in her remarks, we are fully excited for this final listening session in this series, as it does bring much needed ground truths of the realities of PEPFAR program oversight and the coordination of implementation on the ground. We look forward to hearing the candid observations of our esteemed panelists and what's needed to achieve and sustain HIV epidemic control in the out years. My name is Dr. Ade Adetosoye, and I am the Director of the Office of Global Health at HRSA, and I will be moderating this panel today. I am joined today from headquarters by Shannon Young, who is the Deputy Director of USAID's Office of HIV Aids. She will moderate the open forum. And following that forum, Brendan Garvin, SGAC's Director for the Management and Budget Office, will close the session as our rapporteur with a summary of all the participants' inputs. Without further ado, I'd like to take a quick moment and introduce our USG colleagues from the field. First, we have Dr. Simon Agalori, who joined CDC Zambia as a country director in 2018 and has focused on building capacity of provincial health offices to ensure that that direct service delivery is provided on the ground and is supported with technical assistance. And his efforts, along with his team, have resulted in rapid scale-up of HIV diagnosis and treatment, allowing Zambia to continue to operate that program during periods of socioeconomic and now public health emergencies. Next, we have Anita Sampson from the USAID Health Office in South Africa, coordinating USAID's supported efforts on the ground in conjunction with the USG team, really with that lens of public health development and sustainability in view. Next, we have Mark Giambroni, the PEPFAR coordinator of the Nigeria program, bringing the lens of what it takes to coordinate all of the USG efforts, along with ensuring the viable participation of host country governments, civil society, multi-lab partners, and of course, all key stakeholders. Finally, today we have Amber Lucero Dwyer, the Peace Corps country director in Malawi, who ensures that the dynamic ability that the Peace Corps has had in reaching marginalized populations around the world with education, health, and social support services is not lost in PEPFAR business. We have asked our panelists to focus their responses to the following 2 questions, and if they're able to include their reflections on a third. The 2 focus questions are, what does the PEPFAR program look like at sustained epidemic control of HIV? What are the main threats to maintaining epidemic control of HIV? The second question is, PEPFAR Strategy Vision 2025 is aligned to the SDG and global AIDS strategies. Are the draft PEPFAR strategy goals and objectives the priority areas for the program to address? Are any missing or in need of refinement? And the third question we ask them to weave in, if there's time, is we have the technical tools to end AIDS as a pandemic, but inequities, stigma, discrimination, and ineffective policies make our collective job more difficult. What specific strategies should PEPFAR pursue to better confront this challenge. So as I mentioned, we're focused on the first two, and if time permits, we will we have asked our panelists to weave in their thoughts on the third question, as it definitely would be great to hear the impact of stigma, discrimination, and inequities on the ability to achieve sustained epidemic control. So moving on, I will go ahead and hand this over to Dr. Simon Aguilori to start us off with answering these questions. Simon, over to you.
Thank you, Dr. Ade. Good morning, good afternoon, good evening, everyone. I feel honored to be part of this panel this afternoon. To answer the questions that were just shared, I just want to share a brief story with you. So a little over 3 years ago, when I moved to Zambia, one afternoon I was driving through the cemetery near my house, and my kids were sitting in the back. They were quiet initially, but after a while, one of them said, "Wait a minute. A lot of these people who are buried on this side of the cemetery, they're kids." And then he started telling me the ages of the kids. And unbeknown to me, the other kid was also paying attention to the other side of the cemetery, and he said the same thing. And as I paid closer attention, I realized that truly there were a lot of kids buried in that segment of the cemetery. I followed up later on to make sure that that cemetery was not for kids, but it was for everyone. And one thing that I also noticed was that a lot of them died in late 90s, early 2000s. So as many of you know, and I think this is not unique to Zambia, in early 2000 in Zambia, over 72,000 Zambians were dying from HIV each year, because of HIV or HIV-associated diseases. And then in 2020, we've seen significant reduction. That was down to 24,000. Obviously, this is still a problem, but that's a significant reduction nonetheless. Life expectancy for Zambian was 44 in 2000. And that improved to 63.5 in 2018. So that's 20 years gain in life expectancy. So when I think about sustainability, that's what I think about. How do we maintain that improvement in life expectancy? How do we maintain the low disability from HIV that we have achieved because of investments through PEPFAR and others? But what does sustainability mean in our setting? And what are the biggest risks to the future? I think the first thing that I think about, honestly, is the funding which PEPFAR provides. The funding that has a massive impact on our programs if it was abruptly reduced or cut. I recognize other threats. I recognize economic hardship. I recognize natural disasters, political insecurity, et cetera, that they can potentially disrupt our HIV program and disrupt our work towards epidemic control. But however, many PEPFAR programs have experienced many of these things, and there's a lot of expertise now in how to deal with them to maintain our program and grow them despite these challenges. As many of you know, commodities and health for human resources account for the bulk of PEPFAR expenditure in most of our countries. So over the last 1.5 decades, PEPFAR's used international implementing partners, most of them academic institutions, international NGOs, to deliver HIV services. Given the emergency nature of the response and the limited technical expertise in supported countries at that time, it made sense to use this strategy. However, it's been almost 20 years now, and I think the question that we need to ask ourselves is this still the best way to achieve or sustain HIV epidemic control, knowing the cost that's associated with it? And also, do we still have very limited capacities in countries in which we work where we need to continue to rely on NGOs and academic institutions? To me, to have a successful HIV epidemic control, we must be purposeful in getting governments to take on direct HIV service delivery so we can reduce the cost. We can start by funding governments to take on most of HRH work for direct service delivery. There are many advantages to this. It's less costly. The additional healthcare workers' costs will be paid at the same level as the government employees. And this will also allow for integration of HIV services to other healthcare services that are generally supported by governments. During emergencies like what we have seen with COVID, services can continue because we know that government healthcare workers were universally exempt from many restrictions that were put in place that many of our IPs were subjected to. Also, in my experience, governments are generally more amenable to taking on salaries than any other program. So they can take on paying for salaries for staff, but it will be very difficult for them to take on the many programs that we implement. Now, how could this work? Fortunately, this is not an abstract idea. Many of our PEPFAR programs, including Zambia, have successfully been doing this. In fact, program direct service delivery in many of our provinces in Zambia is done by the government at a much lower cost, and they achieve the same results as programs implemented by others. And they have definitely demonstrated that they can do it, and they can do it well. So how do we do it successfully? I think a strong technical support to health facilities and healthcare workers for direct service delivery is needed. Building a strong financial and program management systems at subnational level, it's important. The strong data systems to monitor service delivery and document indicators that speak to program sustainability are also essential. Buy-in by the government officials who implement programs at the lower level, leveraging different strengths of PEPFAR implementing agencies to support this. So the current model where agencies are competing against each other had advantages during the last phase in which we needed to scale up service quickly so we can save lives. But for sustained epidemic control, we really need to think about different strategies that support and incentivize collaborative work between agencies. Each US government agency has impressive and unique strengths, and only through respecting each other and those different roles and experience and expertise can we do something that has never been done before. That's create a model for sustained epidemic control and take it to scale. So the priority areas identified in the draft PEPFAR goals and objectives are comprehensive. I believe to successfully implement them and to maintain HIV epidemic control, we need to set targets and timelines for transition of direct service delivery of key HIV programs like testing, treatment, PMTCT, VMMC to government entities. These may not be a one-size-fits-all and will have different transition phases and timelines, but it should be a priority for every country that has achieved HIV epidemic control. We need to support maybe through PPPs, manufacturing of ARVs and other essential commodities near where most of our patients are. COVID has shown that reliance on commodities from India, for example, can have detrimental effect on our programs in Africa. So finally, transition of HIV programs to governments has the potential to help with reducing stigma by normalizing services. So right now, you will hear people say these are special clinics supported by CDC, by PEPFAR, and it's not owned by the government of Zambia. And Zambians associate that with, HIV. But if that were to be transitioned to the government of Zambia, it will be just like any other program, and I believe it will help in reducing stigma. So recently, with Wave 2 and Wave 3, I continue to drive through the cemetery on almost daily basis. And one thing that I noticed was the increase in number of people the number of burials that are happening every day. And that's because of COVID. And my kids have reminded me recently, like, Dad, it seems like you are failing at your work because there are more people dying now from COVID. And it's sort of reminiscent of what was happening in early days of HIV when a lot of people were dying. And I think it's definitely a big threat, but I am confident that if we work together using a different strength, that we can combat this and we can protect the gains that we've made over the years. Thank you, and back to you, Ade.
Thank you so much, Simon, for that. As usual, you have articulated realities on the ground and connected it to humanity. And the reason why we're in this business is really about making sure that the patient's needs are met, however way we do it. And I hear you loud and clear when you talk about the parallel nature of PEPFAR programs in some countries and how it's like, that's the PEPFAR program and this is the rest of the health program. It's really, really important to think through what integration looks like and how we line up the host country government as a true partner and as a true driver of this next phase as we go forward. So your thoughts on data systems and leveraging USG agencies' strengths to support what the government is doing, really, really heard loud and clear, and also the need for collaboration among USG agencies to ensure that this vision goes forward, also heard loud and clear. I did want to take a moment, and we'll come back to you, Simon, during the question session. But I did want to take a moment to acknowledge the fact that we were supposed to have a DoD representative Monday with us, but she was unable to join because she lost a family member over the weekend, and wanted to share with DoD that our thoughts and prayers are with our colleague during this time. So I'm going to move on to Anita Sampson from USAID, the USAID office in South Africa. Anita, over to you to answer our first two questions. Thank you.
Thank you very much, Doctor, and thank you so much for this incredible opportunity to share. I will turn my video for sound and bandwidth, and then I'll get started. So when I look at the vision and the PEPFAR strategy for 2025, I am so pleased with how comprehensive it is. And I really need to congratulate the team for having made sure that we have such a comprehensive vision. I have a couple of things that I think that we could do a little bit better as we look forward about how we would maintain epidemic control. And these are just ways, building on what Simon has just said, of how we should embed our program across the entire health, social welfare, and education system. And I think that is a key piece that would be great for us to be more inclusive of other departments so that our programs are able to continue within the government strategies. I think that's a big piece as we move forward. As we look to transform our program, it really isn't a reduction of programming, it's how we are going to integrate our programming into something that the government will continue. In South Africa, looking at the two government-to-government agreements that we've been able to get off the ground with Department of Basic Education and Department of Social Welfare, both of those have, as Simon said, reduced the costs of an international implementing partner, maintained and exceeded some of the targets we had set before, and of course are now fully integrated into the government budget that will allow them to continue implementing well beyond PEPFAR, and for us just to provide the technical expertise, the data management systems, and clear targets as we move forward. I think when I'm looking at some of the strategy things, I would love to see us intensify our focus on prevention, particularly on biomedical prevention. There's so many innovative areas coming out of this year, and perhaps we should consider thinking about an earmark around PrEP for the future, how we could really figure out how we can keep the most vulnerable adolescent girls negative using the innovative areas that are coming out of the PrEP arena right now. Our DREAMS activities and programs, as Anjali showed in her slide, we're starting to see the effect of those across multiple countries, and really to try and maintain a footprint in the DREAMS area would be fabulous. I think we're only starting to see the effect, and if we continue to invest in that in a couple more years, we'll really be able to see the incredible change we've been able to make in making sure that we reduce the infections around adolescents and young people. I do think that in our strategies, KP is a little bit underrepresented, and there's some areas that we can really focus on, particularly working with the children of key populations as well as key populations themselves. I also think that we need to really articulate what the end game looks like. What happens when we get to epidemic control? How do we move from the race to epidemic control to the embedding of some of the activities that we've had so much success with, and really look at the areas where we haven't been able to have the kind of dramatic effect that we expected. And I think that's particularly around peds and around children living with HIV that are under 15. As we mentioned, they are underrepresented, and there are ways that we need to strengthen that clinic continuum for us to be able to do that in the future. I do think that working with more local partners, more governments, expanding the types of departments we are working with in the future to ensure the integration of our programs, and bringing in ways that we can support vulnerable children around employment would be something that is innovative and something we should really think about as we look at the youth bulge. We look at all these vulnerable children that we are supporting either through our DREAMS programs, our OVC programs, or as CLHIV, and we need to support perhaps through a public-private partnership, how we could continue to support them as they move towards the working ages, employment, bringing funds into very vulnerable households. And then perhaps my final point around this is, PEPFAR has been very, very able to adapt to COVID and to the impact that COVID has had on our programs, just demonstrating to us the incredible platform that PEPFAR has created that has allowed us to be able to access the community health workers, as well as the medical professions and the clinics that we're working with, utilizing them for vaccine purposes. For us to be able to maintain those investments and make sure that when we are working at a district level, that those relationships, they're embedded, they're supported as we move towards the so-called end game. And I really agree with Simon on what he says about how the agencies can look towards working in a more collaborative space as we move towards transforming our programs from PEPFAR identified programs to government identified programs. And with that, thanks very much for this opportunity. Really appreciate it.
Thank you so much, Anita. And I'm picking up some threads in the comments that you've provided, as well as what Simon mentioned earlier. There's definitely, we're hearing loud and clear, a need to really ensure that the government is driving this process if we're interested in sustainability. And how do we embed our program within their strategy for their national responses? So I heard you on intensifying focus on biomed prevention, for example, PrEP. I heard that. I heard the DREAMS success. Yes, the youth bulge is one we cannot ignore. The adolescent population, the children population is definitely growing, and it's the future. We've got to make sure that programs are touching and truly impacting their lives as we move forward. I'm going to move on to, before I move on, I just want to say to all that we will have a session where we will take questions. I see hands raised, you can keep them up, but I just want you to know I'm not ignoring you. We will come to those questions at the end of the panelist presentation. So with that, I'm going to go to Mark Giambroni from Nigeria, PEPFAR coordinator. Mark, over to you.
Hi, everyone. Good afternoon. Thanks for the opportunity to speak today with the rest of my panelists. And thanks for also getting feedback from the PEPFAR coordinator point of view. So I'd like to start with the second question first. And I'd also just like to preempt that the points I'll offer today are coming from a program in Nigeria that started off only 24 months ago as still very much a proof of concept program. Over the last 2 years, we've really made great strides to get closer and closer to epidemic control. And so that's almost kind of forced us to have this sustainability conversation, not only with our own interagency, but also with host country governments at the local, state, and national levels, and then also with our multilateral partners. And so I'd like to start off with really emphasizing the importance of harmonizing the PEPFAR Global Fund relationship. I know this varies from country to country, and there are many different variables that determine the type of partnership, between a PEPFAR country team and a Global Fund country team, and how that relationship will transpire. But aligning our efforts with the Global Fund in a clear and deliberate way will absolutely accelerate our efforts as PEPFAR, and ensure that the Global Fund uses their comparative advantage where necessary. So just as an example, in COP19, as you'll all remember, we had the opportunity to fully align the PEPFAR COP with the new Global Fund grant process. So this really allowed us to go back to the drawing board and discuss where each of our strengths were, and allow us to fully utilize them behind a common goal. And so PEPFAR Nigeria did go through this exercise, and a prime example that came out of this was really looking into our supply chain optimization and how we procure our commodities. So during COP19, after looking at the data, Global Fund transitioned about 90% of their DSD sites to PEPFAR, which freed up about $180 million for ARVs to be procured within the national commodities pool. So really emphasizing and really deliberately putting in place a Global Fund PEPFAR strategy where each country program works together to ensure that relationship is being fully utilized, I think would be really important. So under goal number 2, I think further emphasizing surveillance and the need to increase capacity for a country-owned and managed data repository will be essential, especially as countries start to move to epidemic control. So building a national repository for HIV that's owned by the host government and supported by all stakeholders will ensure that the data that's being reported and analyzed continues long after PEPFAR is gone. So ensuring that there is an NDR-like structure could then enable host governments to expand to other diseases. So using this type of surveillance for TB, malaria, and other emerging infectious diseases, the most recent example would be COVID. And then I think, just like Anita mentioned, I think that the strategy is very comprehensive. I think there's just a few refinements that can be made, especially as it pertains to key populations. As countries get closer to epidemic control, the remaining patients are most likely the most vulnerable, so our key populations. And such is the case in Nigeria, absolutely. So if we're trying to address key barriers, I would expand upon the emphasis to remove these barriers specifically for key populations. So another example, in the past 24 months, our program has really saturated at a rate that we did not expect. So our program has turned from a predominantly general population program to a more focused key populations program. And again, this is just due to the rate that we've been able to saturate, which COVID kind of forced us into, which is a more community-based approach. So I think that in the meantime, we've kind of leaned a lot on our civil society colleagues and local key population organizations to not only act as gatekeepers in the community, but also key advocates in the human rights space. So as we move towards sustaining the gains that we've made, it will be important to identify those that will keep the momentum, even if when PEPFAR's footprint changes. I won't say completely leaves, but changes, because as we know, we are on an annual budget, and the PEPFAR budgets do fluctuate. So second, it will be important to institutionalize key policy directives at the state and federal level as it pertains to HIV, and include provisions for KP service delivery as part of the overall national guidelines. This is something that we recently did, and it basically institutionalizes KP services streamlined across the country. It doesn't matter who is programming, either Global Fund or PEPFAR, but each KP is receiving the same services nationwide. So when it comes to some of the major threats to maintaining epidemic control for HIV, this is a little bit where I become a fatalist, and I don't really have the specific answers, but I do know that it's difficult to say what a program will look like at sustained epidemic control because there are so many other factors involved that are outside of the PEPFAR program. So one of the main threats to epidemic control, I would say, is resources. So pulling resources out too quickly, especially without a plan with the host country government in place, I think would be detrimental to sustain the gains that we've made. And this is something that we're currently going through right now here in Nigeria, where like I said, we're kind of being forced to start these conversations. And then the second threat, I would say, political will. Host country governments change over and priorities change. There are so many different factors that go into managing a host country health system, and many times HIV kind of falls to the wayside. It's just not a key priority. So ensuring that that we maintain political will in a way that we can institute policies and legislation that ensures that HIV services are included into national healthcare schemes and other programs, I think will be essential. So with that, I will turn it back over to you. Thanks, Ade.
Thank you so much, Mark. And I think the beauty of this panel is, getting that focused perspective from the different agencies and, of course, PEPFAR on the ground and how these things truly work. So another thread that I'm picking up here is really a focus on key POPs and the fact that these populations are extremely marginalized and are living in environments where their lifestyle, their lives are criminalized and further pushes them in the shadow. And until we are able to sort that out, really that continues to be a threat to achieving sustained epidemic control. And we've got to figure that out. Very happy to hear what's happening in Nigeria, that there are actually policy directives at subnational levels. I think it's true. That's how we institutionalize that type of impact. The other thing that I'm hearing as well from you, which is very showing up again, this is the third time, is this need to work with the governments and to allow them to drive the strategy, and then PEPFAR supports it and embeds within it, and so that they truly own the direction of how this goes. I mean, if we're talking about sustainability. I liked what you brought up, Mark, about aligning with the Global Fund. I think that is a key point. And again, from your perspective, from where you sit, I think that comes across very strongly. And so really appreciate the thoughts that you brought here. I'm going to move on to Amber Dwyer Lucero from Peace Corps. She is the country director in Malawi, and it would be really interesting to hear your perspective. Over to you, Amber.
Thank you so much. And thank you very much for the invitation to participate today. I think my name is coming up as my husband's name, who works for USAID. I'm on his account, but rest assured, my name is Amber. In Malawi in 2016, the FIA results for Malawi the FIA results for Malawi has been issued, and it was upon my arrival that I realized that I might have the opportunity to be in Malawi when it had while it achieves epidemic control. And I can't tell you how exciting that was for me. It's so exciting for me to be here still, knowing that Malawi has achieved epidemic control. So it's just really exciting to see that progress. And I just want to give a big shout out to our interagency colleagues on the PEPFAR Malawi team. I have watched every single one of my interagency colleagues just do incredible, incredible work in incredible partnership with each other, with the host country government, to really make sure that we reached epidemic control, and to do all of that with a lot of grace and agility through the COVID pandemic. So it's just really, I just want to say how grateful I am to be working with such stellar interagency colleagues. I also just want to give a quick update on the status of Peace Corps, which for those of you who do not have Peace Corps programs in your country, you might be wondering. So Peace Corps volunteers were around the world were evacuated from all posts in March 2020 due to the COVID pandemic. And at this point, every country is working to return volunteers to the country when the conditions are conducive. So it's not a time-bound return, but it's a conditions-based return. And as we continue to go through successive waves, we're continually adapting and trying to make sure that we are able to bring back our volunteers when the conditions are conducive, but also in a way that would prevent us from needing to re-evacuate them due to another wave. So that is an ongoing but I will say that Peace Corps staff, especially I'm going to speak about Malawi, our efforts on the PEPFAR side have not stopped in the absence of Peace Corps volunteers. We have also had to adapt. In particular, our staff here in Peace Corps Malawi have been continuing the HIV prevention work in the place of the volunteers and continuing to work with our communities that used to host Peace Corps volunteers on how they can continue that HIV prevention work in their absence. And also, most importantly, how to do that in a COVID-safe environment, because much of Peace Corps' work is about bringing people together. So we have to reteach our community counterparts on how to do that in a COVID-safe way and provide them the necessary PPE and training to do that. So I just wanted to give that a little bit of preamble. I also wanted to just tell you about how I look at the 95, 95, 95 goals through a Peace Corps lens, which is a little bit different than our interagency colleagues, but maybe that can give you a little bit of my particular perspective. The 95, 95, 95 goals are, as we know, a strong clinical approach, but we also know that there's a behavior attached to each of those goals. The first 95, to help everyone know their status, there's a behavior that's associated with that, which is the desire and willingness to get tested. So we consider that from a Peace Corps lens to be a behavior that we want to promote, helping people make that decision to get tested. The second 95 of getting onto treatment is another behavior. So it's a clinical strategy, but there's also an important behavior attached to it. And then the third 95 of viral load suppression has a very strong behavior attached to it, which is adherence to medication. So for Peace Corps, because we do not approach this from a clinical approach, we look at those behaviors and we think about how do we strengthen those behaviors to contribute to those 395s. And so that's what I think that the sustaining epidemic control looks like, is strengthening those behaviors that contribute to those 395s. And I also want to include an additional behavior which goes before the first 95, which is prevention, and we've heard that as well. That investment in prevention is huge on the behavior component. We've also talked about the clinical, such as PrEP, but there's really important behaviors that go along with that, and that's what Peace Corps focuses on, which is delaying sexual debut, reducing the risk of sexual activity, reducing gender-based violence, and the host of life skills and decision-making skills and education skills that go along with contributing to those very important behaviors. So for Peace Corps, it's about sinking into those behaviors on the prevention side, and then also reinforcing those behaviors that contribute to those three very important 95s. So that's what epidemic control looks like for us. And that really involves, for Peace Corps, working with those partners at the community level, especially our community leaders, our schools, our faith-based organizations, and our community-based organizations, especially with youth. I want to also reiterate what some of my colleagues have said about AGYW, and we've seen just wonderful results that have come out of the DREAMS program in many countries, including here in Malawi. And we've really appreciated the investment that we've done in adolescent girls and young women here. Because there is such a big investment and a host country embrace of AGYW here in Malawi, we at Peace Corps have also branched into our other acronym that maybe isn't as used as much, which is adolescent boys and young men, ABYM. Because we recognize that our adolescent girls, they're at most risk from older men or young men, And so I want to encourage us to really think about that investment in boys and young men as an investment in our girls as well. So here in Malawi, we do a grassroots soccer program that's specifically targeted towards young adolescent boys and young men to teach them about behaviors such as alcohol abuse, addiction, domestic violence, of course, HIV prevention, because we want them to be the partners in girls' futures. And so I want to make sure that the boys are brought into that conversation and seen as a real key instrument toward protecting or reducing that HIV infection rate for girls. I'm going to talk about what I think I just want to introduce a couple more. One is just a psychological threat, which is complacency, right? I feel like we are at the beginning of the start line for a marathon, and everything that we've been doing to get to epidemic control has brought us to that start line. But now we're ready for the race, and it's a long race. And so we don't want to get complacent about our where we're at with epidemic control. But the real hard work is ahead of us, sustaining it. Right. So I just want to, kind of mentally prepare us for that. That complacency is one of those, psychological threats, in addition to the real threats, that come along with funding and partnerships. But I also want to stress that partnership. I feel like, the strength of PEPFAR really rests upon its partnerships amongst the interagencies for the US government, with our host government, with our multilateral partners, and with our communities and our health centers and our faith-based institutions and our civil society organizations. It's been really impressive for me to be part of that. And any one of us is considered that key, stool leg. So take away any part of it, and we've got a three-legged stool and won't do as much. So just strengthening those partnerships, recognizing that that is a key ingredient that it needs to be the glue for all of this, is really, I think, an important part of sustaining that epidemic control. I just want to also just thank everyone who put together the vision, the 2025 vision. I was very impressed with how comprehensive the vision and the goals and objectives are. I just want to reiterate that from my USA colleague Anita. This is a multidimensional kaleidoscopic approach, and it all feels like it's there, like I can see every part of it. And so I just want to thank everyone for recognizing that holistic nature to this program, and also I can also see how each partner plays a role in it. So I don't have any specific comments on it. I just want to thank everyone for the amount of listening that you've done to all the key stakeholders, and making sure that everyone's voice and part to play in it is reflected in the Vision 2025. So I'll stop it there for now. Thank you again for the invitation, and I look forward to any questions. Thank you.
Thank you very much, Amber, and for qualifying the fact that that is your husband's account, because I was like, who's Brian? I appreciate your perspective. I mean, the psychological ideas that you brought up, and the fact that it doesn't only extend to who we work with, but also extends to us, right? That we do avoid, us being USG, that we avoid that complacency, and that we really push through to get through to the end of this. Appreciate that. I think that's something that we tend to forget about as we push on all the other sides for achieving our targets and trying to meet our goals, that we keep that in front of our minds. I appreciate the updates on the status of the volunteers. I think that was very helpful for us to know, and also to know that everything is in play. You're bringing them back as conditions improve. Appreciate that. And then also the targeted focus on behavior. You're absolutely correct. Each of these goals is predicated on the idea that someone will change your behavior, right? And so, to go get that test, you have to be willing. To be put on treatment, you have to be willing. To come back for your viral load test, you have to be willing. And there is a place, there's a role for all of us to play in impacting that behavior change in terms of sustainability. So thanks for bringing up that focus. And also, the thread again that we're picking up is AGYW, but I liked that thought you brought up about ABYM. It's something that comes up in different country contexts about how we do need to bring the boys in as an investment in the girls, right? So even changing the way boys think about girls so that girls don't continue to be victimized is very important. Averting and reducing violence against women comes through changing the way men think about women. So that point really well taken. And then also, back to what Anita had first brought up, that you also reiterated, this idea that it's multi-sectoral, and that we think about that and how we can include that thinking into the next vision, I think is also key. So I'm looking at time here. We are at 9:01. I'm going to just do one check of all of our panelists to see if there's any pressing thought that you have before I turn it over to Shannon, who will moderate the open forum for us. Okay, I see no hands raised. So I'll turn it over to you, Shannon, to help us move through the next phase here. Thanks to all of the panelists, and I'm looking forward to hearing the reflections from our participants today.
Thanks, Ade. And first of all, thank you so much to the panelists for sharing your thoughts and insights and experience to help shape the next PEPFAR strategy. I think it's exciting for me to see almost 650 participants on the call from around the world. And I appreciate that people have already started adding thoughts in the chat. So given that this is the USG listening session, we'd love to hear others' thoughts on the 4 questions posed to the panelists as well. So I'm going to paste them into the chat, and then please feel free to raise your hand if you'd like to share. Okay. So I see Tembeka's hand is up. Is there something that you'd like to share? Or maybe that was not on purpose.
Hello, can you hear me?
Hello. Yes, please go
Yes.
ahead.
I just wanted to, I read through the strategy. It is indeed very, very comprehensive. I just wanted to know in terms of the investments and PEPFAR investments, and whether the strategy can really deal with the COVID situation to reverse those gains. Is it that adaptable post-epidemic control? Do we think we can be able to make sure that we remain resilient however long the COVID situation remains, especially in the Southern Africa region? Thanks. Over.
Thank you for that question. And I think, generally speaking, as this strategy is being developed, we're definitely keeping, the COVID pandemic in mind and kind of pandemic preparedness more broadly and how important that is. So I appreciate that comment. Looking in the list, I don't see anybody's hand raised currently. Let's see what we have in the chat. Don't be shy. Please feel free to raise your hand if you have a comment or question. I can do awkward silences, so we're good.
There are some questions in the chat, Shannon. Do we want to read some of those out?
I do, yeah, I can read some of the questions. I'm hoping to get some people's comments just so that we can incorporate them into the strategy. Okay.
It looks like we
Shannon,
also
can I
have
make one? Sorry.
There's a
Can I
hand
make-
up from Paige as well.
Go ahead, Mark.
Sorry, I didn't mean to jump in there. Just while you're looking for some of the questions in the chat, you know, there was something that Simon mentioned about really looking into other offices or other bureaus to possibly partner with some aspects of PEPFAR that may not be specifically earmarked for PEPFAR dollars. And one example could be, I know DRL does these annual human rights-based grants. And this is something that we've tapped into here because, you know, for a lot of countries, our only avenue into key populations is really through health services, so the human rights narrative kind of gets pushed to the background because that's just not something that we can outrightly fund, at least to a large extent. We tend to focus more on the HIV service delivery when it comes to key pops. So really, you know, emphasizing the need to collaborate with other state entities to further integrate some human rights programming is something that we can take a look into. Thanks.
Thank you, Mark. And I see that Mahesh has your hand raised.
Oh, hi, everybody. Can you hear me, Shannon?
Yep, we can hear you.
Okay, great. No, thanks. I mean, I wrote some of this in the chat, but I think there was an awkward silence, so I thought I would fill it. You know, I guess one of the things I just wanted to raise is sort of how do we think about what do you define as sustainability? So I think a lot of what I've heard about sustainability is essentially how do we increase our numbers or strengthen HIV control with the budgets that we have, or even in reduced budgets, right? So you take the Nigeria example that Mark talked about. A lot of Nigeria's success has actually occurred with a decreasing funding envelope, and in part because, and one, you know, for example, I know that in 2013, 2014, the amount that was budgeted per patient that was supposed to be put on treatment, as well as the amount that was budgeted per I think, well, patient was actually much higher than it is now, but the outcomes in Nigeria are much better than they used to be, and the number of patients who are achieving those outcomes have improved, right? And I think a lot of that goes to some of the things that Mark was talking about, right? So we think about sustainability as in how do we squeeze more out of what we have. I think a lot of what we talk about makes sense, but if you think about sustainability as actually, you know, our funding envelopes are going down and maybe the US government's allocating resources towards maybe some other public health or some other priority, and the host countries are actually running their own HIV program. By running it, I mean not with our money, but actually paying for it through some other means. To me, sustainability becomes a political discussion and less of a technical one, right? That do our host countries or host governments have the same interest in achieving epidemic control as we do? And are they willing to allocate a significant proportion of their resources to that, right? Because I agree that they would spend less per patient in terms of absolute dollars, but the proportion of their government budgets or GDP would be much higher than we would, for example, spend perhaps in HIV control. So I don't know what the answer to that is and how that fits into PEPFAR strategy and how we would feel about that, because all of our budgets ideally should be going down, and eventually some of us should find something else to do.
No, thank you, Mahesh. That's a great point. And it's also, you know, important that you pointed out that, you know, sustainability can mean funding services and it can also mean managing services, which are not always the same thing. So I appreciate that. I'm going to read, oh, I see Jerry Guamna. Raise your hand. Please go ahead. Jerry, would you like to speak? Okay, we'll come back to you. I'm moving to JB. Okay, I see you lowered your hand. So there's some really great comments in the chat on mental health and how to incorporate that into the strategy. I'll just read one of them out loud that I thought was really helpful and instructive. There seems to be an opportunity to better integrate and promote trauma-informed care. Our populations have histories of trauma and continue to feel the effects of trauma, i.e. gender-based violence. There's a need for our services to not only be client-centered, but trauma-informed and move clients toward overall wellness and not just managed on treatment. Solomon, I see that you have your hand raised.
Hi, can you hear me now?
Yes, please go ahead.
Okay. So my comment is going to be a little bit not politically correct, but I'm trying to, I've been thinking a lot about the way we care for HIV patients. And we've been providing care for HIV patients for a long time, nearly 20 years, right? And we started HIV care at a time when most of those infected by HIV were very sick. They couldn't get, they lost their jobs, they became poor and all of that. But over time, we've been able to empower people that are infected. They've become healthy, they've gone back to work. And essentially, the people living with HIV now follow the normal distribution curve, where you have the poor, those that are in between, and then the very rich. They follow the same pattern that you see with any other disease. And when we talk about sustainability, looking forward now, we have many other diseases that are affecting people, our population. And essentially what we do is that we provide a system through which everyone can have access to care and then sustain their care over their lifetime. Because HIV is essentially becoming a chronic disease. So what I'm looking at in Nigeria, we're thinking about having an insurance system, for example, where people infected with HIV can have access to care and can be part of the and can contribute to their own care, just like everyone does in society. For example, we have people that have hypertension, diabetes, and essentially they buy into existing systems to be able to provide for their own care. Whether we like it or not, donor funding for HIV will not be available forever. So I was thinking, can we begin to think of establishing systems that can outlive all of us? So that if someone has HIV in 20 years' time, they just tap into the existing system, contribute to their own payment, and then continue to have their own care. I understand when we started, a lot of our population were very poor, but looking forward now, we have a lot of people going back to work and able to earn a living. Can we begin to think about a system when we talk about sustainability that takes the bill off government, takes the bill off donor, but establishing a system that can inherently continue to exist irrespective of whether government is paying for it or whether donor is paying for it, like any other disease that we have right now. I didn't hear any of the panelists talk about that, so I just thought to put it out there. Over.
Thank you, Solomon. I love that. I love, pushing us to kind of think about not only financial sustainability in terms of transitioning services over to host countries, but what systems need to be in place to pool risk, to strategically purchase health services. That's a great point. I see Simon. Please go ahead.
Thanks, Shannon. And Solomon, you raised a pretty good point, and I think that's what many of us, at least for me, that's what I was getting at with the recommendations that we made. Because, I mean, it's been 17 years, right? So it will not be wrong for Congress to ask, what have we accomplished in terms of building systems in 17 years that will, if we have not been able to build things that can be transitioned to the government, who's to say if we get funded for 17 more years, we're going to be able to do it? So I think what we're trying to get at is we need to force ourselves to thinking about strategies that can allow us to work with the governments, with what they have in place. I mean, at the end of the day, it's all about preventing new infections and making sure that those who are living with HIV are able to live long lives. And I think these are things that we can do in a simpler way that do not require, working with experts from the US, international NGOs, academic institutions, there are enough people within the countries in which we work now that can do this work. It's just about putting our heads to task and coming up with different ways to do it. In Zambia, we're doing it. We work through provinces to implement programs in 4 provinces. You can look at our program data over the last 2 years. They have been able to achieve the same results that other implementing partners are able to do. So the capacity is there. It's just a matter of changing the way we think about things, because we cannot keep doing this indefinitely. That's just not possible.
Thanks, Simon. So another interesting point in the chat that I want to put out there in case anyone wants to add their thoughts or comments. I think some interesting angles to introduce to the discussion include fee for service for HIV on a sliding scale in a way that makes sense and is affordable. Integration into routine healthcare services, i.e. primary healthcare, the same way all other chronic diseases are managed. And I see Han, your hand is raised. Please go ahead.
Great. Thank you so much, Shannon. Hi, everyone. It's great to hear the voices from Team Nigeria, which I was a part of. And Ade, it's great to see you as well in your new role. Congratulations. So my one comment really ties in feedback that I think many of our colleagues have also provided related to some of the psychosocial and behavioral aspects of sustainability. And what I would really like to see in the PEPFAR strategy and the vision for 2025 is our ongoing commitment to address some of the social enablers that allow for the achievement of the 95-95 targets. And what I really mean by this are the 10-10-10 targets that I've seen promoted and advanced by UNAIDS. And I think it's a really important part of the work that we do as a US government. I was really inspired by the statement that was put forward in the multilateral meetings on the global HIV response, which in many ways reinforces the really important role that we play to elevate and prioritize the voices of people living with HIV, of key populations, of women and girls. And it's these efforts that we need to continue to do in order to really achieve the programmatic targets that are also just as important for sustained HIV control.
Thank you, Han. I appreciate that. And that aligns very well with a lot of comments in the chat around how are we planning to incorporate civil society voices? How are we planning to incorporate, a human rights agenda? So I appreciate that. Jerry, I'm going to try going back to you again. Do you have a comment that you'd like to make? Okay, I'm going to assume that might. Oh, there you go.
Yeah, so thanks. Yeah, actually, I've been struggling with the unmuting. It's like I get muted back and I try and wasn't going through. Thanks, Shannon, and thanks everybody for the contributions thus far, especially our panelists and Angeli with the earlier presentation. I think I just wanted to re-echo something I put on the chat in regards to the fact that sustainable epidemic control might look different for different countries based on where they are in terms of their health systems and how, again, they finance health services, as well as other things that, affect the HIV epidemic. So is it possible that we allow host-country government as well as other stakeholders define along together with the PEPFAR teams in country what they want to see as a sustainable epidemic development control, rather, in the way they plan it? Does this strategy allow for that? Is it because, like Solomon mentioned, it may look different for different countries. They may have different ways to come across, about it or get to achieving it, depending on their resource envelope and other priorities as well, but then making sure they still sustain that epidemic control the way they would see best with all the resources they have within. and the systems they have also built up, like Simon also mentioned earlier. So those are things I'm wondering if the strategy allows for, and can that be incorporated? Thank you.
Thanks, Jerry. That's a great point. And I mean, one could argue that there's no such thing as sustainability or sustained epidemic control if it's not aligned with, you know, a country's definition of sustainability. So that's a really important point. Thank you. Okay, I don't see any raised hands currently. Okay, I'm gonna go ahead and read a comment on the theme of greater interagency coordination and cooperation within PEPFAR, and given the persistent need, oh shoot, for sustainable and scalable data systems for HIV, COVID, and other health domains at country and global levels. Will there be resources for further evidence generation so that we may better prioritize the most effective approaches for the most at-risk subsets of the population? How can we develop and utilize feedback and insights from participants? Great point. As we transition to country ownership, Objective 3.4 could be strengthened by ensuring these partners, especially adolescents and youth, are involved early in program design, as too often they are included later in the process and without opportunities for decision making. I think that that's a great point and something that we need to keep in mind. I mean, that's true for adolescents and youth. It's true for local partners, et cetera, and local governments, where are we bringing them in more as an FYI in the end, or are we actually incorporating their thoughts into the design process? So that's an excellent point. Thank you. And I know it's hard to put yourself out there with such a large audience, so I really appreciate everyone who's been willing to put your thoughts in the chat and verbally as well. Thank you.
Shannon, if I could just come in quickly to say, yes, thank you to everyone who has raised remarks or comments, as well as put them in the chat. We have note takers that are, feverishly taking notes throughout the session, and everything that is noted in the chat, we're capturing as well. So again, your input, your comments, your feedback are critical. So keep them coming, even if you don't feel comfortable raising your hand and speaking. We're capturing the other points that are coming through.
Paul, please go ahead. Paul, are you able to unmute?
I am now. Can you hear me okay?
Yes, there you go. Thank you.
Oh, good day, everyone, and thanks for the presentation. I believe what I'm hearing a lot of when it comes to sustainability and the future of PEPFAR has focused mostly on our governments and country operations. But I think we also have to realize that we are all a part of PEPFAR as well, those in the USG who are based at headquarters. So I'm not sure what that future looks like. Sustainability for PEPFAR, I mean, as a pediatrician, part of what we do is almost think about putting ourselves out of business, like eliminating childhood illnesses and diseases. And so what I guess, at some point hearing what the future of PEPFAR looks like for the USG-based community, not just at headquarters, but in the field as well. There's a model of staff and support that we have allocated to these activities, from implementing partners to funding staff. Does it look the same going forward? I'm not sure what that number is, but you have to imagine that resources allocated to support HRH from the USG and PEPFAR stance, is that sustainable? And if not, then what does the future support of PEPFAR looks like going forward? And maybe that's a conversation to have at some point when we do more self-reflection on what do we look like, and not more so what does just what the governments look like in the near future. Over.
Thank you, Paul. That's a great point to wrap up on, actually. I want to thank everyone again for all of your comments and for participating in this session. I'm going to hand it over to Brendan, our rapporteur, to wrap us up. Thank you.
Thank you so much, Shannon, and thank you, Ade, for the wonderful hosting, and thank everyone for their comments. This has been super helpful for me, and I'm sure it has been for others on the call. Just wanted to quickly run through some common themes that I was picking up on throughout the discussion and the various questions and answers. And I think one big one is kind of the theme of sustainability and partnerships, right? And sort of the need to kind of look at our partnerships in a number of different ways. Looking at kind of partnerships with the government, I think, was one of the really big themes that came out of this. You know, the idea that, you know, as you get increased country ownership and you can get the governments to take on more of the costs in a responsible way, you sometimes reduce what you're paying for those costs, paying for those services. Also, the importance of the integration of HIV services into government systems, and that there's an effectiveness element there, but there's also a stigma reducing element there. I thought that was a really, really interesting and important point, and that it's not just about the cost, it's also about mainstreaming what we're doing for the good of our clients. So, you know, we need to also look at working broadly with governments, right? The idea that, you know, as PEPFAR evolves, we need to be working with a variety of different governmental actors across kind of the national and local levels, and that we need to be looking maybe at agencies that we haven't typically worked in the past as we move from kind of like an initial phase to a more sustainable and long-term phase. We also talked about sort of partnerships with respect to the Global Fund, making sure that we have very kind of comprehensive plans for how we're working together so that we're able to be effective. Looking at partnerships through things like PPPs, right? The idea that we need to think creatively about who we're working with to sustain our programming. And then we also talked about kind of the collaboration amongst the PEPFAR family, right? This idea that maybe our future needs to look a little bit more collaborative than sometimes folks feel maybe it has been in the past. So again, sustainability and partnerships. Also a need to focus on important capabilities, right? So, you know, as we move towards sustained epidemic control, there will still be a pretty large need for technical support. And we heard here a lot, I think, around data systems specifically, and also surveillance, right? And ultimately the idea of national repositories, so that the data isn't just something that is part of kind of the PEPFAR program for what we're doing now, but that it resides in the countries for their use in the future. I think the other theme I heard was prevention and the importance of looking at that comprehensively and creatively. So continuing a lot of the interventions that we've been doing in DREAMS, continuing to look at PrEP as a really key intervention that helps make sure that we can keep people safe, and focusing, you know, the continuing focus on AGYW, but also the focus on adolescent boys and young men, right? The idea that there has to be a partnership there if we're going to get these prevention efforts right. I think I heard a lot about key populations. Rightly so, that, you know, we need to make sure that they're not left behind, and that we're continuing to remove barriers and institutionalize services. So again, if we look at kind of that institutionalization of services within the government and the removal of stigma, we need to make sure that we're doing that specifically for our key populations as we move forward. I heard a couple of times, you know, we can't keep doing what we have been doing forever, right? So I think an acknowledgement of the need for kind of change and evolution. So I think it's good that that's what we're hearing. And then also kind of a note that we need to look specifically at the US footprint, right? And that this can't just be about our interface with partner governments, but it also has to be how we're organized amongst ourselves. So those were kinds of what I would say were the themes that I heard that seemed to be common throughout what folks were giving. I did also note just sort of a few what I would call threats. So again, these are things that we just need to keep our eye on, right? So a big one that I heard was the idea of funding and that we don't remove it too quickly, right? So the idea of making sure that the transition is a smooth one and one that is thought out rather than precipitous. I think we heard a lot about kind of the threat of lack of political will, right? Especially as you move towards more governmental ownership. If the political will is not there, that does create kind of a critical threat for the program. We talked a little bit about, again, like key populations. If we're not taking care of their needs, that's a threat for our program. Complacency, right? The idea that, you know, as we get success, we have to make sure we keep our issue on the front burner so that people can't kind of push it to the back and let it languish. And then last two, I think, Lack of collaboration. So again, the positive was that we need more collaboration. The threat is that if we don't get there, it hampers our program's ability to move forward. And then finally, the challenge of the parallel nature of USG assistance, right? That, a lot of the way that we might have to look at things going forward is a bit broader than PEPFAR has been in scope. And we're not always kind of organized the way that the funding streams work within the United States government to be able to do every single activity within one program. So overall, heard a lot of support for the strategy. Again, some common themes where we might want to look and make sure that it's beefed up, and a few threats where we might want to make sure that as we look at the strategy, we make sure that we have comprehensively addressed those threats as part of the final strategy that is ultimately codified. So again, thank you so much for everyone's participation and for the wonderful moderation. And then Anjali, I don't know if you had any last words, but that was my summary. Thank you.
No, that's perfect. Just thank you very, very much, everyone. We will stay in touch. Please stay well, please stay safe, and please take care. This concludes our session. Thank you.